Macular degeneration, Wikipedia article audio. Macular degeneration, also known as age-related macular degeneration, is a medical condition which may result in blurred or no vision in the center of the visual field. Early on there are often no symptoms. Over time, however, some people experience a gradual worsening of vision that may affect one or both eyes. While it does not result in complete blindness, loss of central vision can make it hard to recognize faces, drive, read, or perform other activities of daily life. Visual hallucinations may also occur, and these do not represent a mental illness. Macular degeneration typically occurs in older people. Genetic factors and smoking also play a role. It is due to damage to the macula of the retina. Diagnosis is by a complete eye exam. The severity is divided into early, intermediate, and late types. The late type is additionally divided into dry and wet forms, with the dry form making up 90% of cases. Signs and symptoms. Risk factors. Prevention includes exercising, eating well, and not smoking. Antioxidant vitamins and minerals do not appear to be useful for prevention. There is no cure or treatment that returns vision already lost. In the wet form, anti-VEGF medication injected into the eye, or less commonly laser coagulation or photodynamic therapy, may slow worsening. Supplements in those who already have the disease may slow progression. In 2015 it affected 6.2 million people globally. In 2013 it was the fourth most common cause of blindness after cataracts, preterm birth, and glaucoma. It most commonly occurs in people over the age of 50, and in the United States is the most common cause of vision loss in this age group. About 0.4% of people between 50 and 60 have the disease, while it occurs in 0.7% of people 60 to 70, 2.3% of those 70 to 80, and nearly 12% of people over 80 years old. Signs and symptoms of macular degeneration include: macular degeneration by itself will not lead to total blindness. For that matter, only a very small number of people with visual impairment are totally blind. In almost all cases, some vision remains, mainly peripheral. Other complicating conditions may possibly lead to such an acute condition, but few macular degeneration patients experience total visual loss. The area of the macula comprises only about 2.1% of the retina, and the remaining 97.9% remains unaffected by the disease. Even though the macula provides such a small fraction of the visual field, almost half of the visual cortex is devoted to processing macular information. Environment and lifestyle. The loss of central vision profoundly affects visual functioning. It is quite difficult, for example, to read without central vision. Pictures that attempt to depict the central visual loss of macular degeneration with a black spot do not really do justice to the devastating nature of the visual loss. This can be demonstrated by printing letters 6 inches high on a piece of paper and attempting to identify them while looking straight ahead and holding the paper slightly to the side. Most people find this difficult to do. Recurrence ratios for siblings of an affected individual are 3 to 6-fold higher than in the general population. Genetic linkage analysis has identified 5 sets of gene variants at 3 locations on different chromosomes as explaining at least 50% of the risk. These genes have roles regulating immune response, inflammatory processes, and homeostasis of the retina. Variants of these genes give rise to different kinds of dysfunction in these processes. Over time, this results in accumulation of intracellular and extracellular metabolic debris. This can cause scarring of the retina or breakdown of its vascularization. Genetics. Genetic tests are available for some of these gene variations. However, pathogenesis of macular degeneration is a complex interaction between genetics, environment, and lifestyle, and presence of unfavorable genetic factors doesn't necessarily predict progression to disease. The 3 loci where identified gene variants are found are designated, such as that in the MTND2 molecule, predicts wet AMD. The pathogenesis of age-related macular degeneration is not well known, although a number of theories have been put forward, including oxidative stress, mitochondrial dysfunction, and inflammatory processes. Specific genes. The imbalance between production of damaged cellular components and degradation leads to the accumulation of detrimental products, for example, intracellular lipofuscin and extracellular drusen. Incipient atrophy is demarcated by areas of retinal pigment epithelium thinning or depigmentation that precede geographic atrophy in the early stages of AMD. In advanced stages of AMD, atrophy of the RPE or development of new blood vessels result in death of photoreceptors and central vision loss. Mitochondrial-related gene polymorphisms. In the dry form, cellular debris called drusen accumulates between the retina and the choroid, causing atrophy and scarring to the retina. In the wet form, which is more severe, blood vessels grow up from the choroid behind the retina which can leak exudate and fluid and also cause hemorrhaging. Pathophysiology. Early work demonstrated a family of immune mediators was plentiful in drusen. Complement factor H is an important inhibitor of this inflammatory cascade, and a disease-associated polymorphism in the CFH gene strongly associates with AMD. Thus an AMD pathophysiological model of chronic low-grade complement activation and inflammation in the macula has been advanced. Lending credibility to this has been the discovery of disease-associated genetic polymorphisms in other elements of the complement cascade including complement component 3. A powerful predictor of AMD is found on chromosome 10q26 at LOC 387715. An insertion/deletion polymorphism at this site reduces expression of the ARMS2 gene though destabilization of its mRNA through deletion of the polyadenylation signal. ARMS2 protein may localize to the mitochondria and participate in energy metabolism, though much remains to be discovered about its function. Stages. Other gene markers of progression risk includes tissue inhibitor of metalloproteinase 3, suggesting a role for intracellular matrix metabolism in AMD progression. Variations in cholesterol metabolizing genes such as the hepatic lipase, cholesterol ester transferase, lipoprotein lipase, and the ADP binding cassette A1 correlate with disease progression. The early stigmata of disease, drusen, are rich in cholesterol, offering face validity to the results of genome-wide association studies. In AMD there is a progressive accumulation of characteristic yellow deposits, called drusen, in the macula, between the retinal pigment epithelium and the underlying choroid which is believed to damage the retina over time. Amyloid beta, which builds up in Alzheimer's disease brains, is one of the proteins accumulating in AMD, which is one of the reasons AMD is sometimes called Alzheimer's of the eye or Alzheimer's of the retina. AMD can be divided into 3 stages: early, intermediate, and late, based partially on the extent of drusen. AMD-like pathology begins with small yellow deposits in the macula, between the retinal pigment epithelium and the underlying choroid. Most people with these early changes still have good vision. People with drusen may or may not develop AMD. In fact, the majority of people over age 60 have drusen with no negative effects. The risk of developing symptoms is higher when the drusen are large and numerous and associated with disturbance in the pigmented cell layer under the macula. Large and soft drusen are thought to be related to elevated cholesterol deposits. Early AMD is diagnosed based on the presence of medium-sized drusen, about the width of an average human hair. Early AMD is usually asymptomatic. Intermediate AMD is diagnosed by large drusen and/or any retinal pigment abnormalities. Intermediate AMD may cause some vision loss, but, like early AMD, it is usually asymptomatic. Early AMD. In late AMD, enough retinal damage occurs that people have symptomatic central vision loss in addition to drusen. The damage can either be development of atrophy or the onset of neovascular disease. Late AMD is further divided into 2 subtypes based on the types of damage: geographic atrophy and wet AMD. Intermediate AMD. Dry AMD is a broad designation, encompassing all forms of AMD that are not neovascular. This includes early and intermediate forms of AMD, as well as the advanced form of dry AMD known as geographic atrophy. Dry AMD patients tend to have minimal symptoms in the earlier stages. Visual function loss occurs more often if the condition advances to geographic atrophy. Dry AMD accounts for 80–90% of cases and tend to progress slowly. In 10–20% of people, dry AMD progresses to the wet type. Complement factor H on chromosome 1 at location 1q31.3, HTRA serine peptidase 1/age-related maculopathy susceptibility 2 on chromosome 10 at location 10q26, complement factor B/complement component 2 on chromosome 6 at 6p21.3. Geographic atrophy is an advanced form of AMD in which progressive and irreversible loss of retinal cells leads to a loss of visual function. Neovascular or exudative AMD, the wet form of advanced AMD, causes vision loss due to abnormal blood vessel growth in the choriocapillaris, through Bruch's membrane. It is usually, but not always, preceded by the dry form of AMD. The proliferation of abnormal blood vessels in the retina is stimulated by vascular endothelial growth factor. Unfortunately, because these blood vessels are abnormal, these new vessels are fragile, ultimately leading to blood and protein leakage below the macula. Bleeding, leaking, and scarring from these blood vessels eventually cause irreversible damage to the photoreceptors and rapid vision loss if left untreated. The transition from dry to wet AMD can happen rapidly, and if it is left untreated can lead to legal blindness in as little as 6 months. To prevent this from occurring and to initiate preventative strategies earlier in the disease process, dark adaptation testing may be performed. A dark adaptometer can detect subclinical AMD at least 3 years earlier than it is clinically evident. Age-related accumulation of low molecular weight, phototoxic, pro-oxidant melanin oligomers within lysosomes in the retinal pigment epithelium may be partly responsible for decreasing the digestive rate of photoreceptor outer rod segments by the RPE autophagy. A decrease in the digestive rate of POS has been shown to be associated with lipofuscin formation, a classic sign associated with AMD. Late AMD, dry AMD, geographic atrophy, wet AMD. The role of retinal oxidative stress in the cause of AMD by resulting in further inflammation of the macula is suggested by the enhanced rate of disease in smokers and those exposed to UV irradiation. There is a loss of contrast sensitivity, so that contours, shadows, and color vision are less vivid. The loss in contrast sensitivity can be quickly and easily measured by a contrast sensitivity test like Pelly-Robson, performed either at home or by an eye specialist. When viewing an Amsler grid, some straight lines appear wavy and some patches appear blank. When viewing a Snellen chart, at least two lines decline. Preferential hyperacuity perimetry changes. In dry macular degeneration, which occurs in 85–90% of AMD cases, drusen spots can be seen in fundus photography. In wet macular degeneration, angiography can visualize the leakage of bloodstream behind the macula. Fluorescein angiography allows for the identification and localization of abnormal vascular processes, using an electroretinogram. Points in the macula with a weak or absent response compared to a normal eye may be found. Farnsworth-Munsell 100 hue test and maximum color contrast sensitivity test for assessing color acuity and color contrast sensitivity. Optical coherence tomography is now used by most ophthalmologists in the diagnosis and the follow-up evaluation of the response to treatment with anti-angiogenic drugs. Mitochondrial dysfunction may play a role. Diagnosis of age-related macular degeneration rests on signs in the macula, irrespective of visual acuity. Diagnosis of AMD may include the following procedures and tests. Best's disease. Sorsby's fundus dystrophy is an autosomal dominant retinal disease characterized by sudden acuity loss resulting from untreatable submacular neovascularization. Stargardt's disease is an autosomal recessive retinal disorder characterized by a juvenile onset macular dystrophy, alterations of the peripheral retina, and subretinal deposition of lipofuscin-like material. A 2012 Cochrane review found the use of vitamin and mineral supplements, alone or in combination, by the general population had no effect on whether or not AMD started. Supplements that include lutein and zeaxanthin may slow down the worsening of AMD. They have, however, not been shown to prevent the disease. There is not enough evidence to determine if statins have a role in preventing or slowing the progression of AMD. Anti-angiogenic steroids such as anicortave acetate and triamcinolone acetonide have shown no evidence in preventing visual loss in people with neovascular AMD. No medical or surgical treatment is available for this condition. Oxidative stress. It can be treated with laser coagulation, and more commonly with medication that stops and sometimes reverses the growth of blood vessels. A randomized control trial found that bevacizumab and ranibizumab had similar efficacy, and reported no significant increase in adverse events with bevacizumab. A 2014 Cochrane review found that the systemic safety of bevacizumab and ranibizumab are similar when used to treat neovascular AMD, except for gastrointestinal disorders. Bevacizumab, however, is not FDA approved for treatment of macular degeneration. A controversy in the UK involved the off-label use of cheaper bevacizumab over the approved, but expensive, ranibizumab. Ranibizumab is a smaller fragment, Fab fragment, of the parent bevacizumab molecule specifically designed for eye injections. Other approved anti-angiogenic drugs for the treatment of neovascular AMD include pegaptinib and aflibercept. The American Academy of Ophthalmology practice guidelines do not recommend laser coagulation therapy for macular degeneration, but state that it may be useful in people with new blood vessels in the choroid outside of the fovea who don't respond to drug treatment. There is strong evidence that laser coagulation will result in the disappearance of drusen but does not affect choroidal neovascularization. A 2007 Cochrane review found that laser photocoagulation of new blood vessels in the choroid outside of the fovea is effective and economical method, but that the benefits are limited for vessels next to or below the fovea. Diagnosis, histology, prevention. Photodynamic therapy has also been used to treat wet AMD. The drug verteporfin is administered intravenously. Light of a certain wavelength is then applied to the abnormal blood vessels. This activates the verteporfin, destroying the vessels. Cataract surgery could possibly improve visual outcomes for people with AMD, though there have been concerns of surgery increasing the progression of AMD. A randomized controlled trial found that people who underwent immediate cataract surgery had improved visual acuity and better quality of life outcomes than those who underwent delayed cataract surgery. Because peripheral vision is not affected, people with macular degeneration can learn to use their remaining vision to partially compensate. Assistance and resources are available in many countries, and every state in the U.S. Classes 4 or independent living are given, and some technology can be obtained from a state Department of Rehabilitation. Adaptive devices can help people read. These include magnifying glasses, special eyeglass lenses, computer screen readers, and TV systems that enlarge reading material. Computer screen readers such as JAWS or Thunder work with standard Windows computers. Also, Apple devices provide wide range of features. Studies indicate drusen associated with AMD are similar in molecular composition to beta amyloid plaques and deposits in other age-related diseases such as Alzheimer's disease and atherosclerosis. This suggests that similar pathways may be involved in the etiologies of AMD and other age-related diseases. A practical application of AMD-associated genetic markers is in the prediction of progression of AMD from early stages of the disease to neovascularization. Cell-based therapies using bone marrow stem cells as well as retinal pigment epithelial transplantation are being studied. A number of trials have occurred in humans with encouraging results. There are a few other kinds of macular degeneration with similar symptoms but unrelated in etiology to wet or dry age-related macular degeneration. They are all genetic disorders that may occur in childhood or middle age. Similar symptoms with a very different etiology and different treatment can be caused by epiretinal membrane or macular pucker or any other condition affecting the macula, such as central serous retinopathy. Dry AMD2. Wet AMD2. Adaptive devices. Epidemiology. Research directions. Association with other age-related diseases. Genetic testing. Stem cell transplant. Other types. Notable cases.